Friends, it's a great honor to be here for the first Dr. B.R.R. Verma oration, and I would take this opportunity to thank the office bearers of SPIK, COPS, and of course our dear friend Dr. Biniraj for considering me for this prestigious memorial oration lecture. The topic which has been allotted to me for this oration lecture is implantology and integrated speciality. And greetings to all of you from my institute, the Ranjit Deshmukh Dental College and Research Center, Nagpur. Functions of such grades, and the topic which has been allotted to me is implantology and integrated speciality, and I consider it my proud privilege and would offer this presentation as a tribute to one of the legendaries in the field of periodontics, Dr. B.R.R. Verma. We all know Professor Verma as one of the senior teachers and a thorough gentleman. And though we have not been directly associated with him as students, but then we had the opportunity to interact with him in national conferences of the Indian Society of Periodontology. And I must confess over here that whenever we met him, whenever we interacted with him, during these interactions, we felt that every time he would offer us something new in the basics, something new ideas, new concepts, and we were thoroughly enjoying the deliberations we had with him. Sir was a thorough gentleman and a doyen of periodontal teaching and research. He had quite innovative ideas with regards to teaching methodologies and also ideas regarding the research which can be undertaken in the field of periodontology. So I offer this presentation as a tribute to this great personality. Friends, dental implants is one therapeutic modality which has enabled us to take into consideration the patient's functional requirements as well as aesthetic requirements. And these are some of the pictures of some of the high rises which are situated in different geographical locations. But then even though they have been located in different geographical locations, they have one thing in common, and that one thing is the strong foundations on which these buildings have been placed. Similarly, drawing an analogy over here, drawing a parallel over here, if we consider dental implantology, the dental implants, if we want them to last for a longitudinal period, and if we want them to be successful, they need to be placed in strong foundations, or at least in deficient areas, the foundations need to be recreated so that we can have success in implant therapies. Often implantology, there is a lot of debate whether it is a single person's domain or whether it is a domain of a single specialty, so on and so forth. But we all firmly believe that it is a team which would work on a single vision, and that is success in implantology as far as restoring the masticatory apparatus of an individual. And the debate with regards to alignment of implantology to a particular specialty, be it a maxillofacial surgeon, be it periodontics, be it prosthodontics. But then I would consider, over the experience of my 2 decades in implant therapies, I would consider implantology as one of the specialties which would belong to a clinician. It would belong only to a clinician who is ready to enhance his skills through upgradation of knowledge and also integrate the inputs of other specialties so that we can gain maximum for the patient. The patient benefits the maximum from all the inputs, be it the prosthetic inputs, be it the surgical skills inputs, be it the soft tissue inputs, or be it the inputs from some other dental practitioner. It has often been said that beauty lies into the eyes of the beholder. But then even the beholder needs to recognize and appreciate the proportionate presence of the white and pink aesthetics. And this proportionate presence of white and pink aesthetics lies in the optimal scalloping, proper contouring, presence of interdental papillae, and also symmetry of the tissues on either sides of the midline. But most of the times what fault we do is we falter at the thing that we ignore the yellow foundations, which are so very important, because these soft tissues, the soft tissues are often known to follow the hard tissues. And so these are the areas which we need to concentrate upon. And this proportionate presence of the yellow foundations is also so very important for attaining aesthetics into implant therapeutics. Now, before venturing into any of the implant therapeutics, it is pertinent to know the biology of the tissues which are associated with implants. And this biology of the tissues would differ in terms of the mechanical resistance, the presence of supracrestal collagen fibers, the vascularity, and also the regenerative ability of the tissues. Now, if we consider these two figures over here, the first one is the natural tooth and the second one indicates the implant associated peri-implant tissues. Now, the major difference lies into the positioning of the collagen fibers. The collagen fibers, these are the SEM pictures, scanning electron microscopic pictures, which would indicate the perpendicular presence of the collagen fibers, whereas in cases of implant, they are placed parallel to each other and long axis of the implant. So this presence of parallel fibers parallel to the long axis of the dental implants would make them more vulnerable for early breakdown. The strength is less, the resistance to masticatory forces is less. So though we have tried to mimic the nature to a certain extent, but then we are not in a position to completely replicate it into our artificial substitutes. And in addition to that, we have poor vascularity, which would lead to a lesser regenerative ability. The regenerative ability which is seen in natural dentition would be much more as compared to dental implants. And these points we need to keep into our minds. And because of these, there are inherent characteristics of the mucosal tissue which is associated around the dental implants, because it is not only the dental implant which is important, but then the health of the tissues which are which lie peripherally to the implant are also important. And these tissues injure easily, they inflame readily, they infect with ease, they react to insults slowly and defend weakly, and many a times they mirror the systemic health. So it's of utmost importance to examine the implant therapeutics or the patients who have been treated with dental implants on a regular basis. Now, this regular basis, if the oral hygiene maintenance of the patient is appropriate, then it can be placed at once in 6 months or once in a year, depending upon the clinician's suitability and clinician's preference. Now, again, with respect to the areas wherein we need to restore the masticatory apparatus, we come across several situations, and these situations need to be identified. These situations need to be examined properly. And this examination would be in terms of these three clinical situations which I have put over here. The first picture would indicate the edentulous site and the duration of edentulousness. Now, if we go by the literature, the first year after tooth extraction, more than 30% of the bone volume would be lost if the tooth is not replaced or if the replacement is not done. But then this replacement has to be in terms of maybe an implant substitute, because if we go in for a substitute with regards to a partial prosthesis or a fixed partial prosthesis, the same amount of bone resorption would continue. And so we require some sort of stimulation to these tissues so that the volume of the alveolar bone would not be resorbed at such a faster rate. The second one would be extremely good case. Now, if you go on to see, check the width of the tissues or the edentulous area, it's almost about 7 to 8 millimeters in dimensions. And it would enthuse a lot of us over here for going into placement of dental implants over here. But then examination of the adjoining tissues is extremely important over here. Now, if you can appreciate this spot over this spot and the sulcus over here, or the pocket over here, there's pus oozing out from the tissues. Don't go just by the inspection of the areas. We need to examine the adjacent tissues so that we are able to diagnose what is going on within the tissues, whether there is infection which is present within the tissues. Because if at all we have active periodontal infection in the adjacent tissues, we would not be in a position to have successful results as far as implant therapy is concerned, because it would be detrimental. This infection would be detrimental to the health of the implant, and there would be a faster rate of peri-implant resorption as compared to a healthy tissue. And the third one, I'm sorry, this is a post-operative image, but then what we need to be careful is about the mucogingival or mucosal keratinized mucosa width. This is extremely important, and many a times this aspect is ignored by a lot of clinicians. Now, this was a case wherein the patient was treated with implants, and the patient was planned for implant-supported complete denture. Now, what happened in this case, I would tell you a brief background about this. 2 implants were placed, and this was the implant stud. What happened is, because of the minimal width of keratinized mucosa, after 15 days or so, the patient started feeling discomfort. Now, this discomfort was owing to the movement or the mobility of the soft tissue over the implant stud. Now, this implant stud over here, and because there was no width of keratinized mucosa, the soft tissue would move along with the movements of the lips or the masticatory movements, and this caused a lot of discomfort. Now, this discomfort resulted into inflamed tissues. There was inflammation within the tissues, and it led to a gross enlargement of the size of the soft tissue over here, which led to a gross discomfort and pain to the patient. Now, the patient came in that condition to us, and we had no other alternative than to go in for increasing the width of keratinized mucosa, which was done by a vestibular extension procedure. Now, this is the post-operative image, which indicates a good width of keratinized mucosa over here, and the patient was later on treated with the complete denture in that region. Inadequate attached gingiva or keratinized mucosa would lead to these consequences. All of you would have gone through this. These are similar to what are present in periodontics, what are taught in periodontics. But then many a times in our enthusiasm, in our zeal to treat our patients in the same visit or in a short span of time, we often ignore these conditions, which cause a lot of problems, not only for us, but then also for the patient as well. And many of you would argue with the fact that since it is possible to treat a complication post-operatively, why not go and place the implant in the same sitting and maybe wait, if at all there is a complication which arises, it can be taken care of at that point of time. But then this is not in the best interest of the patient as well as the clinician, because what happens is the management of soft tissues around the implants when the tissues are inflamed becomes much more difficult as compared to healthy tissues. So it is always better you would have a clean surgery in cases wherein the tissues are healthy as compared to cases wherein the tissues are inflamed. So it's always better to have a detailed examination, do pre-implant surgical procedures which are indicated in a particular case, and then move on for placement of dental implants. Now, coming to several of the influencing factors, there are several soft tissue and hard tissue influencing factors which we would be discussing and deliberating about in this presentation. The first half of my presentation is basically stressing on these factors, and the later half of my presentation would come up with some of the cases which we have treated in our department, which did have multidisciplinary dimensions. Now, on a lighter note, everybody is aware about these two funny characters, the Laurel and Hardy. And similarly, taking an analogy over here, we have the thin and the thick influencers. The thin influencers would have a minimal effect over the success of implant therapy, whereas the thin would have a minimal resistance to the peri-implant dehiscences, whereas the thick ones would be more resistant to peri-implant dehiscences. And from this point of view, these two periodontal biotypes or the soft tissue biotypes are important, especially for the clinicians. Though it may appear that these are routine matters, but then if we go on to see longitudinal studies, if we go on to see implants placed in thin biotype, periodontal phenotype, or thin mucosal phenotype, what appears is after a certain period of time, if the placement is not appropriate, there could be occurrence of peri-implant dehiscences, which are really very cumbersome for management of the tissues. So ideally, if we identify these type of influences initially, we can modify our placement of the implant in a particular case. Then as far as the influences goes, the free gingival margin and the tooth position, they do influence the peri-implant aesthetics, wherein the free gingival margin, if it is more coronal, then definitely it would be more resistant. It would have low risk as far as peri-implant dehiscence is concerned, but then if it is more apical, then it falls into the high risk category. Similarly, for the gingival form, if we have a flat scallop, which would indicate a thick biotype, then definitely the risk would be low. Whereas in a high scallop, especially which is seen in ladies or female patients, we would have high risk. Whereas this is again the biotype. Then tooth shapes also, which is one of the aspects of periodontal phenotype, and the osseous crest position. If we have the osseous crest position which is highly placed, then it accounts to a low risk, whereas if it is a low crest, it would account to a higher risk. So the outcomes depending upon the risk, favorable and unfavorable. So we need to be aware about these aspects before we begin into placement of dental implants. The critical dimensions in implant placement needs to be observed quite appropriately, because if this vertical distance exceeds the vertical distance from the crest of the alveolar bone to the cemento-enamel junction, or the crest of the gingival papilla exceeds 5 millimeter, then there are more chances of these spaces going into black triangles, getting converted into black triangles. Whereas if it is lesser than 5 or lesser than 5, then the chances of having or encountering black triangles or gingival deficiency in the interproximal area would be reduced to a great extent. So is the case with the horizontal distance. Now the horizontal distance, if it exceeds 3 millimeters, then definitely there are more chances that the interproximal width would be more. And with the more interproximal width, it would be a risk as far as papilla deficiency is concerned in that area. And also, if it is lesser than 3 millimeters, then also it is again a risk, because if the two implants are placed close to each other, or even if the implant is placed to a natural tooth very close to the natural tooth, it becomes a problem, because the alveolar bone in that area would lead to resorption, and definitely the soft tissue would follow suit in the coming days. Now, as far as the various specialities which are aligned in implantology, we need to be very aware about the radiographic inputs, because radiographic inputs are so very important as far as success of implant therapy is concerned. And this radiographic inputs can be taken preoperatively, intraoperatively and postoperatively. Now, I would suggest to have the third phase on a regular basis. Once in a year is an ideal time to examine the tissues as far as whether there is any presence of any pathology or so. The first one is again important, and the second one, maybe in the initial phases, one would require the phase 2, wherein we are not so accustomed to placement of dental implant, or we are not accustomed to the tissues. We can go in for phase 2 as well. These are several of the imaging modalities which can be adopted as far as the examination of the tissues is concerned. Though we have multiple of them, but then what one needs to be aware is, one needs to be aware about the ALARA principle, which indicates as low as reasonably achievable. Now, it would mean that the dosage of radiation should be as minimal as possible, and the output or the information which we want to gather from the radiographic inputs should be as maximum as is possible. So the radiographic input should be maximum with a minimal radiographic dosage for that patient, which is in the best interest of the patient, and so we need to fulfill the ALARA principle. But then, in cases of implants, what is observed is many a times the two-dimensional radiographic pictures do not satisfy the information which is required by the clinician. And just as has been appropriately said by a famous cartoonist, late R.K. Lakshman sir, that in the days of monsoon, one needs to have a three-dimensional mindset wherein one needs to be aware, prevent himself from the fury of rain gods, the splashes from the roads, and also the most what you call unwanted splashes from the co-passengers. Similarly, for dental implant therapeutics to be successful, one needs to have a three-dimensional approach, one needs to have three-dimensional examination of the tissues so as not to fall into any complication, so as not to cause any discomfort to the patient. And this is owing to the vital structures which are present. Now, if we talk about the maxilla, we have the greater palatine nerve, we have the maxillary and nasal sinuses, we have the incisive canal, the mental foramina, and the mandibular canal. So all these vital structures need to be protected, need to be taken into consideration when we are deciding about the size of the dental implant, whether it is the length, whether it is the width, and also the position in which the dental implant needs to be placed. So all these things need to be taken into consideration, and this exact idea about the measurements or the dimensions which are available as far as the recipient tissues is concerned can be obtained by a three-dimensional radiograph, and that is the CBCT in cases of dental implant therapeutics. Now, there would be a sort of argument with regards to the incisive canal. What we have been taught is that the incisive canal is placed in between the two central incisors on the palatal aspect. That is the sole thing which we have been taught about in our textbooks. But then there are a lot of variations which do occur, and these variations were studied by Tozum et al., wherein the authors studied 933 CT images of the anterior maxilla. And what the authors found out that the mean canal length was 10.86 millimeters and the mean canal diameter was 2.59 millimeters. Have these dimensions enthused anyone over here? I'm surprised. Definitely not, because we are not going into these dimensions of the incisive canal. What we are more interested in is into the clinical implications it would have on our therapeutic modality. And these clinical implications can be had from the more interesting factors which are mentioned in the second picture. What these authors found was, majority of the times, definitely there's a single incisive canal, but then there is a possibility of having two incisive canals in between the central incisors on the palatal aspect. It is not only the two incisive canals. At times there could be a Y-shaped incisive canal, a single incisive canal having a Y-shaped at the coronal aspect. It does not limit itself to this. It could be this variation as well, wherein the Y component would have an additional tributary on one of the aspects. And again, this is the most complicated amongst them. So if we get a patient of this sort of variation, then definitely we are going into, we might go and land up into complication. But then to prevent ourselves, what we need to do is we need to have a good 3D imaging before we plan for implant therapeutics. And it is essentially more important if the patient, now this is a third situation wherein we have the natural tooth present. Now this yellow line indicates the long axis of the tooth. The blue line would indicate the position of the incisive canal, and this pink line would indicate the palatal alveolar bone, palatal bone. Now imagine you have an edentulous patient who has been edentulous for a long period of time, for a few years together. There would be gross amount of bone resorption over here. Now this gross amount of bone resorption would definitely bring us more nearer, in close proximity to this incisive canal, which needs to be protected while we are placing the dental implant in that area. So these are the things which are taken into consideration as far as maxillary sinus is concerned. The presence of septa over there. There could be multiple septa which are present, and especially when we are planning for a direct sinus lift procedure or an indirect sinus lift procedure, we need to be aware about these variations. Coming to mental foramina and mandibular canal. Now, mental foramina, as has been taught in our final BDS textbooks, the position of mental foramina would lie somewhere between the root apices of the mandibular first and the second premolar. But then again, one study was done by Josbelli et al., wherein the authors examined 1,000 CBCT images. And what was found by these authors was that it is not only a single position of the mental foramina which is a variation. The variation would lie into multiple positions in which this mental foramina could occur. It could occur as anterior as the root apex of the canine. It would lie in between the root apices of the canine and the first premolar. It could lie in between the two premolars. It would lie at the root apex of the second premolar. It would lie in between the second premolar, root apex of second premolar, and the first molar. And the distal most is the root apex of the first molar. So these 6 different variations in position of the mental foramina are extremely important whenever we are planning to place dental implants into the mandibular aspects. And this is not the only variation which was found by these authors. We have often heard about the posterior loop. The mental nerve, after arising from the mental foramina, would go in a posterior direction. This posterior loop also is somewhat important because it is not only the posterior loop which is present. The variations which have been observed into this are these 5 variations. The mental nerve, after arising from the mental foramina, could go posteriorly, it could go buccally, it could go lingually, it could go in an acute direction, not posteriorly, but in an acute direction posteriorly. So we need to be aware about all these variations in terms of mental foramina and the mandibular canal. The coronaapical and mesiodistal positions are definitely, we have the comfort zone and the danger zone, as has been described by many authors. Again, on the orofacial aspect, we need to have the placement of the implant more lingually or more palatally if we want to have a good amount of facial cortical plate and the soft tissue over it. Now, these are some of the aesthetic influences which need to be taken into consideration, but then would not go into the details of it. One of the most important is the medical status. I would want to highlight over here medical status because of the fact that we encountered one situation, we encountered one patient in which the complications did occur. But then it was not a complication which occurred on intervention, it occurred before the intervention, wherein we went in for pre-examination of the hematologic parameters. We had a young patient. In fact, it was not for a perio reason. The patient had, we have a medical college associated with our institute, and since one of his relatives was admitted in the medical college, this young lad was accompanying the patient. Now what happened is, when the young lad was there, he was supposed to be admitted for 3 to 4 days. He had no other work to do, so he checked into the dental OPD for a routine checkup and maybe cleaning of his teeth. And he landed up into the department of perio. As would be, the postgraduates did examine the patient, and they are more enthused as far as the surgical procedures are concerned. And what they saw was a minimal amount of gingival hyperplasia and gingival enlargement with the first premolar, maxillary first premolar. And that enlargement was hardly of 2 millimeters by 2 millimeters in size, and so in their enthusiasm they wanted to go in for a surgical procedure for excision of this gingival tissue. But then as a matter of routine, we asked the patient to go in for a hematologic examination, and to our utter surprise, this is really mind-blowing. When the hematologic reports came to us, what we found was that the hemoglobin levels for this patient, young patient, 22 years, was 4.2 gram. It was really shocking for all of us. We asked the patient to visit the medical OPD, wherein he was again sent in for further investigations, and the patient was diagnosed with leukemia. Just imagine, had the patient been taken for a minor surgical procedure without having a proper investigation, then definitely it would have landed all of us into complication. Leave apart the patient, but then the entire department would have suffered a lot because of this. We take efforts into establishing our practices. We take efforts into making our patients satisfied with our treatment modalities for years together. And if we come across such a case, then definitely the entire efforts from our side are going to be washed away in a single case like this. So always one needs to be aware about the medical status. Then of course smoking habits is also important as far as success of implant therapy is concerned. The surgical influences, proximity of anatomic structures, we have already discussed about that. The volume of alveolar bone which is present. Restorative influences, we have the condition of adjacent teeth, the interarch distance, and the span of restoration. Many of these are required to be considered. Now, alveolar bone happens to be one of the biologically precious, privileged, and most sought after tissue. But then, fortunately for all of us professionals, dental professionals, it is manageable to a certain extent. To a certain extent, I am saying, because there are limits to augmentation as well. Now, coming to some of our experiences, the clinical cases which we have done in our department. Now, this is one of the most simplest ones amongst them, a healthy tissue over here, good width of alveolar bone, implant in position. This is the implant, and this is the final restoration. Another one, a delayed one-piece implant, but then here there was a slight amount of minimal compromise as far as the width of the alveolar bone was there. However, we could finish it off quite satisfactorily. This is the implant in position, final prosthesis, and this is almost after 8 years. Now, all these cases which we have put over here have a follow-up, a long-term follow-up. Another one, this was one of the initial cases treated by us almost about 10 years back. Now, this was a situation wherein there could be a deficiency which was identified clinically, but the width was around 3 millimeters over here, but then it was a little lesser at the apical region. It happens normally that at the crest you would have a greater width of the alveolar bone, and as you move apically, because of the convexity, you would have the width to be reduced. And this is what was what happened in this case. What we did was we wanted to go in with bone expansion. We did go in for bone expansion, but then we landed into complication of the exposure. Though the primary stability was good, but then there was a buccal exposure. So we went in for augmentation of this area with a barrier membrane, GBR procedure. This was the implant in position after healing. And this is the collar portion. This is the final prosthesis in place. Another one, immediate implants. Root pieces were extracted immediately. A traumatic extraction. Here your surgical skills are tested and implants in place, augmented. This is the final prosthesis in place, and this pre-op and post-op radiographs. Again, immediate implant placement with GBR, root piece extracted, implant in place. This final prosthesis, pre-op, implant in place, implant with prosthesis. Another one, similar one. Now this is an interesting case. It doesn't have multi-department implications, but then this was an accidental case. Unfortunate, really unfortunate for the patient. She was a young lady and a professor in an engineering college. While returning from her duty in the evening on her motorbike, she fell down. She had met with an accident, and with this accident she fell down. She had an impact over her chin area. Now because of the impact, she fell unconscious, was taken by the onlookers to one of the nearby hospitals, and the patient was diagnosed with fracture maxilla and mandible, for which she was treated. Bone plating was done, and later on she was comfortable. This went on for 6 months period of time. After 6 months, she felt discomfort in the maxillary premolar area, and she again went to the same hospital, stating that since the plates have been placed over here, there's some discomfort, pain in that area. So it was a general hospital belonging to a general surgeon. Not to offend any speciality or any profession over here, but then what the doctor did was he went on and removed the bone plates from that area and prescribed some medicines, after which the patient was all right for again a period of 3 weeks. But then again after 3 weeks, this patient realized that she has discomfort in both the maxillary premolar area, and for which she was referred to us. Now what we did was we took the history, we got a minor idea about what could have happened, but then we went in for a CBCT examination in this case. Now this was what appeared to us on the maxillary area. Look at this premolar. A fracture line over here. You have a radiolucency. Another premolar. Again a radiolucency over here. So we got the indication that bone plating was done, and perhaps the bone plating which was done by a plastic surgeon, which we came to know from the history itself. And this was the area in which the screws of the bone plates went into. The screws went straight into the roots of the premolars. And after the removal, it appeared as if a radiolucency over here. We had no other alternative than to go in for extraction. A traumatic extraction was done on the left side. The implant, since it was a first premolar, we had two sockets. We placed the implant in the palatal one, since the buccal cortical plate over here was thin, and augmented the area on the buccal socket, and this was the post-operative one. On the right side, she had swelling over there, a yellow swelling indicating pus formation in that area, and this is after the extraction. There was complete destruction of the buccal or facial cortical plate. So again, fortunately for us and for the patient, it was a first premolar, two sockets, two roots, two sockets. So we could place after debridement, we could place the implant in the palatal socket and augment the facial aspect. These were the extracted teeth. If you see over here, these were the holes for the bone plates. Now she was treated for maxillary implants, but then because of the impact, she had problems with other teeth as well, which we did inform to the patient. Later on, she had pain with this mandibular first molar, and if you can see clinically, there appear to be a lot of fracture lines in this area. So we went in for extraction, and the implant was placed over here. Now, if this was the extracted tooth, this is the fracture line, this is the fracture line, and this goes on almost to the root apex. And this was evident on the occlusal surface. So these were the implants in place, and this was the premolar which was restored. This was the first molar which was restored, and this is the right side which was restored. These are some of the cases which can be treated with particulate bone graft, but then we can go in for a block graft. Would not go into details of it. A few cases: maxillary deficiency, symphyseal graft taken, graft placed, and this is post-operative healing. This is after opening up of the area after 6 months or so. We do have a bone resorption on the lateral aspect, but then the central core had taken up very well, which enabled us to place the dental implant. This is particulate bone graft material for secondary augmentation. Another case, again a block graft. This is the final at the time of retrieval of the screws, and this is the final prosthesis. Block autografts, vertical augmentation in the posterior region. Another side, implants placed, final prosthesis. Now, sinus lift procedures definitely do have a double whammy, in the sense that we have the tendency of the sinus growing apically, coronally, and the bone resorption going on into the edentulous space in an apical direction. So just as the army people at the borders have to manage not only the opponents, the enemies from the opposition countries, but then they also have to manage the internal terrorists as well. So is the case with sinus membrane, wherein we have the bone atrophy occurring over here, which can be taken care of by an indirect sinus lift if it is minimal. This is one of the cases, final prosthesis. Direct sinus lift procedure, wherein we have a major amount of deficiency, implants in place, graft material, the PRF in place. Another one, the severe deficiency, wherein the patient is edentulous, completely edentulous. We can go in for all on four, wherein the Malo guide can be used, implants in place. Now this is the trine point, and this is the final prosthesis, and this was treated by our residents in Perio. So things can be done. The only thing required is your ability, your readiness to adopt and to take up the inputs from other specialities. Some of the cases with compromised outcomes. This was one of the cases treated for immediate implants. Implant was placed, and see over here the post-operative buccal deficiency, the facial deficiency, which we are trying to treat with fillers Another one, indirect sinus lift, done properly, but then unfortunately there's interproximal space over there, a black triangle over there, wherein there are complaints of food lodgement. Socket preservation, another one. But after socket preservation, this were the dimensions. We went in for indirect sinus lift procedure over here, placed the dental implants, final prosthesis, but then you see the deficiency of the papillary tissue in the mesial aspect. So all things we do, all efforts we take, there are situations wherein we get compromised results, and in order to overcome these compromised results, we thought of having a substance which could be which could enable us to go in for acceleration of new bone formation, which would also suppress the bone resorption, increase osteoblastic differentiation, and with a strong antimicrobial activity. We are developing this material. I have purposely not put the ingredient over here because of IPR issues, and we have filed a patent for this. These were the preliminary studies, testimonials, which we did with this molecule. We prepared a gel which can be utilized for such deficiencies, and these are the physical properties of this gel. And this was one of the cases treated with this, wherein we had edentulous, we had the root piece and edentulous area. After extraction, we grafted this area with graft material and of course the gel X. Now this was the result 4 months post-operatively. We could go in for histologic examination because of placement of dental implants. We took the central core by a trephine and examined it histologically, which indicated new bone formation. Now, clinical work would not only satisfy you, your ego as a clinician, but then along with it, we have multiple advantages, and one of the advantages remains that your work can be published in scientific literature. We have numerous publications which have been generated on account of our work which have been done. This one in Quintessence International 2021. This again Quintessence International 2022. This in the Journal of Indian Society of Periodontology 2023. Again in JISP 2023. So renowned journals, one can get the work published after the clinical work is done properly. Now, in order to master yourself, in order to enhance your skill, what is required is your readiness to acquire knowledge and take small efforts day in and day out, because it's only your efforts which is going to make you successful as far as clinicians or your clinical abilities are concerned. So I would appeal all the young graduates, postgraduates to work very sincerely and with empathy towards the patient, so that we can work in the best interest of our patients and achieve excellent results, not only for the patients but also for us to build our names and to satisfy our clinician abilities. So lastly, I would like to thank all of you for giving me a patient hearing. Of course, the office bearers of SPIK and COPS and Professor Biniraj for this opportunity, for this prestigious oration. Thank you.
Thank you, sir, for that informative session. Now I invite Dr. Jiju